All right, in this one, we're going to talk about cardiac physiology. So this will be really helpful to a lot of the M1s in their cardiac unit, people studying for step one and step two, if you just need a reminder of some of the important cardiac physiology that we'll talk about. I also put in a little bit about pulmonary edema, just a small little bit. Um, Nothing about really treatment in this case. More, this is aimed more towards like the step one level, and then a little bit on diuretics as well, because that will help out students when they get into their renal block and for step one. So we'll discuss high your cardiac physiology, and then I have three cases at the end that we'll go through. So big picture, some of our equations that we really need to know. Cardiac output is heart rate times stroke volume, right? So the faster my heart beats, and then the stroke volume is the preload, right? How much are my ventricles actually filling? They're stretching to then contract, right? The combination between how fast my heart is beating, how much they're filling is going to equal how much of that blood we're actually able to push out through the left ventricle, through the aorta, out to the system. And so then our mean arterial pressure is essentially the pressure that is perfusing my organs. And we can calculate that by doing our cardiac output, so heart rate times stroke volume, times the systemic vascular resistance. And all the systemic vascular resistance means is how my vessels in the system are constricting, right? So it's the pressure that my left ventricle and the aorta we have to push against, right? Um, so then mean arterial pressure, another way you can kind of conceptualize it, is 2/3 the diastolic pressure plus 1/3 the systolic pressure. So why do you think we multiply the diastole by 2/3 and the systole by 1/3? So it's because our cardiac cycle, right? Actually, we spend about 2/3 of the time in diastole, relaxation and filling, and only 1/3 of the time in systole, the actual contraction, right? So we calculate our mean arterial pressure reflecting that, okay? This is more of an advanced concept that I would like you guys to understand as you get to step two land, when you're on your IM wards and like the ICU is for most patients, we like to see that mean arterial pressure greater than 65. There's a lot of good literature on that number. When we keep things above 65, we're able to perfuse our brain, right? Essentially, it's the big one we're worried about. And so oftentimes in patients with shock, right? Shock would be a whole discussion for another day, right? That's a multi several hour lecture. But in patients with shock, right, their mean arterial pressure is usually below 65, and we can't raise it without putting patients on things called vasopressors. So the major vasopressor for like septic shock would be norepinephrine. For cardiogenic shock, dobutamine, right? So those are advanced concepts. But when you're on the wards, you can easily calculate a patient's mean arterial pressure. We usually get a little bit better data if we do an arterial line. So we measure the direct flow through the artery rather than a blood pressure cuff. But even on the wards, you can get a pretty decent mean arterial pressure calculation just based off of the blood pressure cuff. Um, and then just like a few definitions. Preload, again, is that ventricular filling, which another name for it is the end diastolic volume, right? So diastole, again, we think about filling, right? And so everything, whenever we talk about the cardiac cycle, obviously what's happening on the right side of the heart is also happening on the left side of the heart. We always just use the left side of the heart kind of as like the role model here, because the left side of the heart is a stronger portion of the heart, and that actually carries out into systemic circulation. So I think about the end diastolic volume as the final filling volume that occurs in the left ventricle right before we contract and go out. Um, Remember, what's the relationship called when we think about stroke volume or preload or end diastolic volume, right? All kind of synonyms for the same idea. So what's the relationship between the end diastolic volume and contractility? What's that relationship called? So that's called the Frank-Starling mechanism, right? So you've probably seen graphs. I don't have any in this PowerPoint, but as the stroke volume, the venous return, the end diastolic volume, as that stretch continues, right? The bigger the stretch we get, the stronger the contraction we can get, right? So then vice versa occurs. The less amount of blood filling my ventricles, the less strong that contraction can be. So then we have our afterload, right, which is resistance the left ventricle has to eject against, right? We kind of talked about that with systemic vascular resistance. So afterload is the pressure the left ventricle contracts against. Contractility is another name for inotropy, right? and that'll shift our end systolic pressure and volume relationship. And then compliance is just the stiffness, right? So what is my equation for compliance? It's real simple. That's going to be change in volume over change in pressure, right? You'll use this again if you guys haven't done your respiratory unit yet. You'll talk about it for lung physiology as well, right? So compliance, how stiff my heart is, right? So in this case, the more compliant the heart, the more fluid we can fill in the left ventricle, right? The more the less compliant my heart, the less fluid we can fill in the right or left ventricle. Okay, so those come into play when we start thinking about different causes of heart failure, which is we might bring it up a little bit here, but it's a story for another day. So pressure gradients, right? Really simple. Flow goes from higher to lower pressures, duh, right? And so the valves open and close based on pressure differences, right? So when we think about right on the right side of the heart, we go, what are the three vessels that drain blood into the right atrium? So it's going to be IVC, SVC, and my carotid sinus, right? So they drain into the right atrium. When the pressure in the right atrium gets higher than the pressure in the right ventricle, we push that tricuspid valve open. We dump flow, we dump our fluid into the right ventricle, right? Same thing happens when the right ventricle, its pressure gets higher than the pulmonary vascular resistance, right? We push open the pulmonic valve. We go over right through the lungs, right? You guys will learn about what happens in the lungs in a little bit. We make our way to the pulmonary veins to the left atrium. When the fluid in or when the pressure in the left atrium builds up stronger than the pressure in the left ventricle, we kick open the mitral valve. Blood will then pool into the left ventricle, right? And then as the pressure in the left ventricle gets stronger than the systemic vascular resistance or my afterload, we kick open the aortic valve and then we shoot out, right? So same idea here, okay? And then we can have valve abnormalities. The two big ones are stenosis and regurgitation, right? So those, when we have a stenotic valve or a regurgitant valve, which we'll talk about in a little bit, we can get abnormal flow patterns across the valve that can lead to murmurs, right? So all four of those big valves I named, right? Tricuspid, pulmonic, mitral, and aortic can all have stenoses or regurgitation. So this you're probably, you guys are all probably familiar with, right? If you did your M1 cardiac unit, right? So this is my pressure volume loop. So essentially, what I want you to just understand, you should be able to go into your exams and just have this essentially memorized in your head, what's going on. They could easily have you just label a point. You might have to draw it out, right? If you have like an open exam. So those are things to understand, right? But it helps me conceptualize what's going on in the heart. So I like to start with point A. So at point A, the mitral valve opens, right? And so when the mitral valve opens, we're pushing blood from the left atrium into the left ventricle, right? So we are now, if we look at our axes, right? The x-axis is the left ventricular volume. The y-axis is the left ventricular pressure. So when the mitral valve opens, we're dumping fluid, dumping blood into the left ventricle, okay? And so at this point, right, the mitral valve is open, but the aortic valve is still closed. So we're dumping blood into the left ventricle, and you see, right, the volume, right? The volume is getting much bigger, right? We're adding volume to the left ventricle, right? So eventually that volume builds up and we have no more volume left to give, right? The left atrium it's bone dry, right? We've gotten everything from the left atrium into the left ventricle. The mitral valve closes, right? And so once the mitral valve closes, no more fluid can get in, right? So the blood in the left ventricle is done, right? No more left in. So the mitral valve closes, and this is what we call my preload, my end diastolic volume, right? All the things we were talking about right there, the same thing, right? Preload, end diastolic volume. Okay, so now the mitral valve is closed, but guess what? So is the aortic valve. Okay, so the left ventricle, all that blood in there, it's kind of just stuck in there, right? But now the left ventricle, it's got all this preload, and it's like, hey, we're going to start contracting to build that pressure up so we can outweigh the pressure in my afterload so we can kick open this aortic valve and kick out all my blood throughout the system. So what happens is at this point, the mitral valve is closed, the aortic valve is closed at point C. We start getting what's called isovolumetric contraction, right? Isovolumetric, volume's not changing, but we're having a contraction, so the pressure goes up. And so that's what we see. We go from C to D, right? If you look on our graph, right, the pressure is going up. We're going up the y-axis, but we're doing nothing on the x-axis, right? And so at a certain point, we have outweighed the pressure in the system, right? And we kick open the aortic valve. And we go to D through E through F, right? So E is my max amount of ejection, right? And then we get to point F, right? Where eventually now we've lost enough of my volume, we've lost enough of my pressure that the aortic valve snaps back shut, right? And so the distance from point D back to the straight line that F and A makes, that's called my stroke volume, right? That is the amount of fluid or blood that is ejected from the left ventricle during systole. That is what the stroke volume is. So at point F, the aortic valve closes, but guess what? The mitral valve is also closed now too, right? So in this case, we're going to start filling the left atrium, okay? And we're going to drop pressure in the left ventricle, right? But there's nothing, because the mitral valve is closed and because the aortic valve is closed, there's no volume that's going into or out of the left ventricle, right? So the pressure is dropping because we're no longer contracting, right? We're slowly stopping that contraction. So the pressure decreases up to a point now where the pressure in the left ventricle is less than the pressure in the left atrium, right? Because at this point, the left atrium is getting all the blood to return from pulmonary circulation, okay? And so that pressure in the left atrium is building, building, building. Left ventricle is just chilling right now because the mitral valve is closed, but eventually that pressure builds up and we kick open the mitral valve again and we start the whole process over. And right, so point A is called the end systolic volume. So it's the amount of volume left in the system after a complete heart contraction, right? Systole. Um, so again, systole is your heart contraction, diastole is your heart relaxation, right? Those make up the cardiac cycle. Um, so what I want you guys to be able to do is to be able to like label these in your head and give a one-liner about what's going on. If you can do that, like I just did, you'll be perfect for your exam. I just gave you guys a reminder here. So S1 is the sound like you guys have heard about S1, S2, there's an S3, there's an S4. We probably won't talk about those during this lecture. But S1 is the sound you hear when the mitral and tricuspid valves are snapping shut, right? S2 is the sound you hear when the aortic and pulmonic valves are snapping shut. Um, in general, the mitral and the aortic valves are under higher pressure, so they tend to close just a little bit sooner than the tricuspid and pulmonic valves, respectively, right? So mitral and tricuspid work together, pulmonic and aortic work together. And so the mitral and aortic tend to snap shut just a little bit sooner than tricuspid and pulmonic. The problem is it's such a small difference that our ears can't really tell the difference. But there are certain cases where the right side of the heart gets under higher pressure than normal, and we can actually get what's called a split S2, right? So S2 is where my aortic and pulmonic valves close, right? And so if I hear a split S2 where, maybe you've learned it, lub dub, right? The lub is S1, the dub is S2. You might actually hear a really quick second sound after that dub. So it'd be like boom, boom, boom. Um, really quick, heart murmurs are really hard to tell the difference between. It just takes a lot of practice. I'm still getting a lot of practice at understanding them. But you might read in a vignette about a split fixed S2 or a split S2. Those can mean a number of things. One of those things is what we call a delayed pulmonic closure, which is usually secondary to what we call pulmonary hypertension, which could be its own lecture on itself. But pulmonary hypertension is where the pulmonary vascular resistance increases for whatever reason, right? Maybe it's the artery, maybe it's a problem with the heart, maybe it's a problem with the lungs, maybe you have chronic clots, or maybe you have a systemic autoimmune disease or something else going on in the lungs, right? That causes the pulmonary vascular pressure to build up. And now my right ventricle has to work really hard. Remember, the right ventricle is not super strong, right? So it's used to pushing pretty weak, right? It doesn't hit the gym like the left ventricle. It's pretty weak because it only needs to push against really weak pulmonary vascular system, right? So if the pulmonary vascular resistance, right, which is equivalent, like think about it, the same as the afterload, right? The afterload is what the left ventricle has to push against, which is my systemic vascular resistance. My pulmonary vascular resistance is what my right ventricle has to push against, right? It's the resistance in my pulmonary vasculature. if those pulmonary vasculature, if they get constricted for whatever reason, right, those new myriad of reasons I listed, if they get constricted and the pressure goes up, right ventricle has to push harder, right? If the right ventricle can hypertrophy for a little bit, but it can't hypertrophy forever, and eventually the right ventricle might give out, and we get what's called right heart failure, secondary to a lung problem. That is what we call cor pulmonale, right? Heart failure could be a story for another day. So really S1, S2 is what we call is mitral and tricuspid closing, S2, S1, mitral tricuspid, S2, aortic pulmonic. So in between S1 and S2, that is my systole, right? Because the mitral and tricuspid are closed and the aortic and pulmonic are open, right? That is me ejecting blood out into the system. When we hear S2, okay, aortic and pulmonic have closed, right? And now eventually the mitral and tricuspid will open. Okay, that is in between S2 then, and the next S1 will be diastole, right? So let me say it again. Between S1 and S2, that is my systole, ejection. Between S2 and S1, that is my diastole. And remember, I told you we spend 2/3 of the time in diastole, 1/3 of the time in systole. So my between S1 and S2, it happens pretty quick. But between S2 and S1, there's a little bit more time when you're auscultating the heart. And if you think about it, right, I'll have a picture coming up about where we auscultate the heart. But if you think about it, right, the aortic and pulmonic valves are best heard up at the base of my heart, right? So aortic valve, right upper sternal border, right, second intercostal space. Pulmonic valve, left intercostal border, like left second intercostal border. Um, Kind of up there. So the left upper sternal border, right upper sternal border, those are the base of my heart, right? So I just told you aortic and pulmonic closing, S2. So I can hear S2 better at the base of my heart, whereas S1, right, tricuspid and mitral closing, tricuspid is better heard at the like usually like the fourth or fifth intercostal space, left lower sternal border. Okay, and the mitral valve is usually like fifth left intercostal space, mid-clavicular line, or what we call the cardiac apex. So your S1 is better auscultated at the apex. Your S2 is better auscultated up at the right and left upper sternal borders, right? My base. Okay. So PV loop landmarks, right? This is just in writing. Literally everything I said. The x-axis is the volume, the y-axis is pressure, and diastolic volume bottom right, and systolic volume bottom left. Stroke volume, right? This is an important equation. End diastolic volume minus end systolic volume. What do we start with? Right at the start of systole. What do we end with? Right at the end of systole, right? And then my ejection fraction is my stroke volume divided by my end diastolic volume, another important equation. For the diagnosis of systolic heart failure or heart failure with reduced ejection fraction, classically it's an ejection fraction less than 40% where we make that diagnosis. Okay, we use an echocardiogram to make that. Um, so these are important. The next three slides. How does the preload change my pressure volume loop, right? So preload again, if we go back, C is my preload, my end diastolic volume. So all we'd be doing, right? This gray box is my control. So that was the graphs we were just looking at. If we increase preload, right? So we get more blood to the right and left ventricle, right? All we're doing is we're shifting that point D over to the right, right? We're increasing volume in the left ventricle and in our pressure volume loop. We still get up to the same point, right? The afterload hasn't changed, right? So I don't need to build up any more pressure, and then we eject, right? So the end systolic volume is still the same. The end diastolic volume has increased, right? So I put that in words here for you. Increased preload or venous return, whatever you want to call it, causes an increase in the end diastolic volume, and we shift it to the right, right? We still have the same afterloading contractility, okay? And the stroke volume ends up increasing, right? Because remember, the stroke volume is this point, right? E to this point here, right? So stroke volume was this point D to this point here, right? So that's my stroke volume. So actually, I think I said this was point D, right? If we go back to our original graph, it's actually point C, so that's my bad. But we're just moving this point out, right? So a classic question for like an M1 exam is they won't have these labeled, and they'll literally give you, here's the control, and now they give you a new preload or a new graph, right? And it literally looks like this guy in red, and they say, which of the following was changed? Was it preload, afterload, contractility, compliance? X, Y, or Z, right? If all we're doing is moving our graph to the right a little bit and the afterload and contractility are the same, we've done something with preload, right? In this case, we've increased it. And in green here, we've decreased preload, right? So we started here, now the preload's less. So the end diastolic volume is less, but again, we haven't done anything to the afterload or the systemic vascular resistance. We haven't done anything to the contractility. So we still get the same endpoint, the end systolic volume, but the stroke volume is way less, right? And so remember, my cardiac output is heart rate times stroke volume. So if I take my control here and they have a cardiac output of X, right? And I say, I want this green guy to have the same cardiac output as my control, right? But let's say his stroke volume in green, let's just say it's half of what this control is, right? In order to maintain the same cardiac output, what does the green guy have to do, right? So cardiac output equals heart rate times stroke volume. So if green guy's preload or its stroke volume has now cut in half, right, his heart rate would have to double, right? So that's why you can see some patients with failing hearts, their heart rate is, it has to compensate, right, in order to maintain some aspect of the same cardiac output as the patient was before they got sick, right? So typical causes to increase, well, we'll talk about some of the maneuvers in a little bit, but to increase preload, the big one I want you to know is like giving them fluids, obviously, and doing a leg raise, right? So blood pools in my legs. So what you can do is as the physician, you can actually raise the patient's legs or you can put the patient in Trendelenburg. It gets some of that stasis blood back to the right side of the heart, and then obviously to the lungs to the left side of the heart. All right, so afterload, same idea, right? We in this case we haven't done anything with preload, right? The preload is staying the same. We're all at the same point, but the afterload, the systemic vascular resistance, right? So this patient has hypertension, right? Their blood pressure is like 180 over, 100, right? So we got to push really hard. The left ventricle has to push really hard. We got to build up all this pressure because remember it's volume, pressure. The left ventricle has to build up all this pressure in order to kick out, right? And eventually, right, that pressure is so high, the left ventricle cannot maintain an immense amount of pressure for so long. So we're actually not able to fully empty out the left ventricle in this case, right? So, because remember, the aortic valve only stays open for as long as the left ventricular pressure is higher than the systemic vascular resistance. It can't maintain that forever. So we're build, all this isovolumetric contraction. We finally outweigh the systemic vascular resistance. We open up the aortic valve, but the aortic valve doesn't stay open that long. And all of a sudden it crashes closed. And now we do isovolumetric relaxation. And if we look, right here is my end systolic volume for the patient with massive afterload. Here's the end systolic volume for a patient with our control, right? So look at the stroke volume. There's my control. And there's my patient with high afterload, right? Way lower stroke volume. Um, so again, same idea, right? Lower stroke volume, heart rate needs to compensate. Heart rate can't compensate forever, right? Our heart rate can't stay, 120 beats per minute forever, right? Eventually that heart's going to fail. And then you think about low afterload, right? In this case, we don't have to build up that pressure as much. And then we can shoot out a lot, right? Because again, the left ventricular pressure will stay higher than my systemic vascular resistance for longer, and we can actually have a much larger stroke volume in these patients. So I wrote it here, right? Increase afterload, the left ventricle ejects less, right? Increase afterload, left ventricle ejects less. The end systolic volume stays higher, right? Boom, here is my end systolic volume. It's higher, right? There's more blood left in the left ventricle at the end of systole than it should be, right? The stroke volume decreases, and then often there's an increase in diastolic volume on the next beat. So these pressure volume loops show you one beat. But if you think about it, right? If there's more blood, let's say we did one full contraction, and in this case, more blood sits in the left ventricle because we can't eject it out. So we're already starting with a little bit of blood in the left ventricle. We're still getting the same dump from the left atrium. So my end diastolic volume, my preload actually might be larger on that next beat, right? Hopefully that makes sense to you. And so again, they can show me this gray clip here, and then they can show me an unlabeled pressure volume loop where nothing changes on the y-axis, but they show me a larger, a taller y-axis and then a decreased end systolic volume and say, hey, what did we change here? Afterload, preload, compliance, contractility. You'd say afterload, right? Adam taught me this. Easy, right? One more for you would be contractility. So contractility is shown kind of by the slope of the angle here, right? So the taller the slope or the more steep the slope would be the higher the contractility or the inotropy, right? So we're not doing anything to volume. We're not doing anything to afterload. It's now how hard does my heart contract, right? The harder the contraction, the better the stroke volume, right? So here's my control. My stroke volume goes from here to here. If we have a stronger activation of the heart, right, stronger contraction, man, I can dump out every last drop that's in that left ventricle. We get isovolumetric relaxation and we see my stroke volumes all the way here. And then if you see, right, here would be a patient with low inotropy, right? Really, really crappy stroke volume, right? So then really, really high end systolic volume. Um, so tell me, what would be an example in real life of why a patient could have better contractility? Think about drugs here. What kind of drugs? And then think about at the same time what would cause low inotropy. So I have it written here, but remember your beta 1 receptors on the heart are really important for heart contractility. They activate CAMP, PKA. We get an increase of calcium heart contraction, right? So your sympathetic activating agents, right? Norepinephrine, epinephrine, right, that we make endogenously can bind to those and cause contractility. So you think about your fight or flight response, right? I want my heart rate to be high. I want my cardiac output to be high to perfuse my brain, my kidneys, my liver, and especially my muscles as I'm running from that bear. But then you can think about, right, a drug like dobutamine, which is a beta 1 agonist we give to patients with cardiogenic shock, right? So the patient's heart has failed out. It's not perfusing anything, and we need to get that heart moving again, right? So we give it a really strong beta 1 agonist like dobutamine. Um, and then you think about low inotropy, right? That would be the exact opposite. What if we gave him a beta blocker like metoprolol, propanolol, nadolol, things along those lines, like esmolol? You guys have probably heard about all these drugs. So we block the beta 1 receptors. We can't get that stimulus from my endogenous adrenergic agents like norepinephrine, epinephrine. So the contractility decreases, right? So as the contractility decreases, the end systolic volume increases, boom. The stroke volume decreases from here to here. It should be here to here. And the ejection fraction, right? Stroke volume divided by end diastolic volume goes into the gutter. Okay. Um, I didn't show you compliance here, but compliance is essentially this guy in green, right? I didn't like explicitly say it, but remember, compliance is how much the heart can fill. So if the heart is really stiff, right, you go through concentric hypertrophy, usually secondary to hypertension or what we call restrictive cardiomyopathy. So you guys may learn about some of the causes of that. Like, so you could have hemochromatosis leading to iron deposition in the heart. You could have amyloidosis, sarcoidosis, lymphoma, eosinophilia, all infiltrate the heart and cause the ventricle to be really stiff, right? So think about, I have a really stiff ventricle. The ventricle used to be able to expand and hold all this blood. Now the ventricle is really stiff. I can only fit so much blood in there, right? So the preload, the end diastolic volume goes way down. So this guy in green would be an example of decreased compliance. All right. Um, this was just everything I said. So I'll kind of just let you guys, if you want to screenshot this, but if we increase the preload, the end diastolic volume goes up. If we, and the stroke volume goes up, if we increase the afterload, the end systolic volume goes up and the stroke volume goes down. We increase the contractility, the end systolic volume goes down, the stroke volume goes up. If we decrease compliance, the end diastolic volume goes down, the stroke volume goes down. Now, yes, you could take a screenshot of this beautiful slide, throw it onto an Anki card, and do like a closed deletion and just memorize it. Sure, that'll get you what you need on an exam, but I want you to try to conceptualize it, try to memorize it, or try to understand it. Because if you understand it, it will make a lot more sense. And again, I know you guys you're thinking more step one level, but one day you'll be on the wards, you'll be in the ICU, and you'll have a patient with a failing heart, and you'll have to think about this stuff. This stuff does come back. All right. So intros to murmurs. Um, we'll kind of jump into murmurs now. So the cardiac cycle again, systole, diastole, right? So in systole, that's my ventricular contraction. So the ventricles contract to eject blood into the aorta from the left ventricle, into the pulmonary artery from the right ventricle. So the valves, again, during systole, the aortic and pulmonic valves are open. My mitral and tricuspid valves are closed. We've already gone over this. Diastole, again, is ventricular relaxation. The ventricles relax to fill with blood from the atria. So in this case, the mitral and tricuspid valves are open, right? And the aortic and pulmonic valves are closed, right? We've gone over this. It's just a review. And then here's those cardiac auscultation spots that we already talked about. So aortic, best appreciated, right upper sternal border, second intercostal space. Pulmonic, left upper sternal border, second intercostal space. Tricuspid, fifth intercostal space, lower left sternal border, and mitral is your apex or the fifth intercostal space, mid-clavicular line. So APTM. I had a student my M2 year, so it was my first year of tutoring here at MCW, and she came up with mnemonic, right? So it's aortic, pulmonic, tricuspid, mitral. She came up with mnemonic Adam Plotkin trains muscles. So if that helps you remember them, then you'll never forget them. Um, all right, heart sounds and timing. So again, we've already talked about this, but just to reiterate, mitral and tricuspid valve closure is my S1. Aortic and pulmonic valve closure is my S2. Between S1 and S2 is systole. Between S2 and S1, diastole, right? And then again, just so you can see it on picture, right? If mitral and tricuspid closing is my S1, I hear my S1 better, louder at the apex. If the closure of my aortic and pulmonic are my S2, I hear those louder at my base, right? All right. So types of valvular lesions, again, I alluded to this, but we can have stenosis or regurgitation of either any of the four valves, right? So when you think about stenotic lesions, the valve should be open, right? It's a partial blockage. You get turbulent flow and a murmur, right? So normally my valves, they're nice and move like this, right? They're nice and open, or they move like this, however you want to visualize them, whichever way you're kind of looking down at the heart or up at the heart. But they open to allow flow in, right? Um, when we have a stenotic valve, the valves get fibrotic, calcified, right? They get damaged, and they're just like these crusty, rusty doors, right? So think about like a door when you first got it, right? You first move into a home, door opens like butter, right? Easy, easy. You live in that home for 40, 50 years, you don't take good care of that home, and now all of a sudden, I used to be able to, I just had to put one hand on the door and it would easily push open. Now all of a sudden I got to use my whole shoulder. I got to jam into the door just to get it to crack open a little bit so I can kind of like slip through. That's a stenotic valve. Um, your regurgitant valves are what we call incompetent valves or insufficient valves. So in this case, the valve should be closed, right? But all of a sudden, like the valve is really leaky. It's like one of those revolving doors at the hotel, really leaky, and it allows backflow. Okay. Um, so stenotic valves should be open, but they're not. They're really hard to open. And regurgitant valves should be closed, but they're not fully closed, right? They're leaking, right? They're like a floppy door in the wind, right? They're leaking and allowing backflow. So knowing that, I don't even need to memorize these murmurs, right? I've got a physiological understanding, right? That's the way I teach everything. Um, so um, Aortic and pulmonic valves, again, they should be open in systole, right? Left ventricle needs to pump blood out into the system, right ventricle into the lungs. So if they should be open in systole, but all of a sudden I hear a murmur during systole in either the right upper sternal border or the left upper sternal border, I'm like, these valves should be open, okay? But I'm hearing a murmur, right? In systole, it's got to be stenosis, right? The valve has to be open. The valve should be open. If I'm hearing a murmur over the right upper sternal border, second intercostal space, and I know it's systole, right? It's got to be stenosis, right? Because the valve should be open, okay? So open in systole, the aortic and pulmonic valves. If it causes stenosis, it's a systolic murmur, right? And again, these valves should be closed during diastole, so if I know it's diastole between S2 and S1 and I hear this weird murmur, I'm like, what could this be, right? I'm over the right upper sternal border, second intercostal space. I know this is S2 to S1. I know it's diastole. Well, guess what? That valve should be snapped shut. It shouldn't be allowing anything in. So the fact that I'm hearing a murmur during diastole, I already know aortic regurgitation, right? Based on where I'm at. So again, let me reiterate, the aortic and pulmonic valves should be open in systole, okay? If they're stenotic, we'll get a systolic murmur. They should be closed in diastole. If they're regurgitant, we'll get a diastolic murmur, right? And then it's the exact opposite in mitral and tricuspid, right? So in mitral and tricuspid, they should be open in diastole, but if they're stenotic, we'll get a diastolic murmur, and they should be closed in systole. If they're regurgitant, we should get a systolic murmur, right? Um, so you can go and you can memorize, and there's a few more lesions that we'll talk about, but like you can go and memorize like all these murmurs. But if you just understand that physiological concept, I don't even need to memorize them, right? I know what I'm looking for. I can understand visually and conceptually what is going on in this patient's heart. Okay. And I'll give you a framework coming up in a minute from Dr. Mansour's book. But core maneuver concept, right? We can do a couple things, right? These two are the big ones we do in real life at the bedside. We can change the preload, we increase the venous return in the left ventricular volume, or we can do something to the afterload, increase or decrease the afterload, which is the systemic vascular resistance. We can change time and diastole by giving a patient like a beta blocker, but that's kind of beyond the scope of step one. So general rule, right? There are exceptions. There's two big exceptions that we're going to talk about in a second. But most murmurs get louder when the flow increases across the valve, right? That should make sense. Increase the amount of flow going across either the stenotic or regurgitant valve, the murmur should get louder, right? There's two exceptions we'll talk about. But if you remember that rule, I don't even need to remember that. I just remember the two exceptions, right? Perfect. Okay, so Valsalva and standing and then squatting and leg raise, right? So Valsalva is straining, right? You can have the patient pretend to take a bowel, or like tell them, hey, like pretend like you're taking a bowel movement and really just bear down. You can have them cough. You can have them kind of breathe, expire against what's called a closed glottis. So you basically close your throat and like really breathe out, right? Really strain. Um, what this does is it increases my intrathoracic pressure. Okay, and again, if you haven't done respiratory physiology, some of this is going to go kind of beyond your head, and you don't have to understand it all, right? Because you'll get this in pieces, and eventually it will make total sense. But normally, when I increase my intrathoracic pressure, just think about the pressure in my chest has gone way higher, right? And so it kind of compresses my left and right ventricles, and that decreases my preload, right? So Valsalva straining down increases intrathoracic pressure, which decreases my preload, right? It makes my right and left ventricle smaller. They cannot accept as much blood, right? So remember another name for this, right? We're decreasing preload. We're essentially making my ventricles less compliant, transiently, right? But less compliant. Um, Smaller left ventricular cavity, right? So most murmurs will get quieter with Valsalva, okay? So remember, um, if we increase the flow across a murmur, most of them get louder. So in this case, we're valsalvating, right? Which is increasing intrathoracic pressure, decreasing preload. So most murmurs get quieter, right? Standing is the same thing. If I stand, blood pools down, less blood going back to my heart, right? Decreases preload. Um, so I just like literally explained Valsalva to you, so hopefully that makes sense. But I get it on these exams, you get stressed, things stop making sense. So if you want like a quick mnemonic, the V in the Valsalva points down, right? So here's my hands making a V, which is making an arrow pointing down. So I just remember that the V points down, preload goes down, right? If the preload goes down, most murmurs go down in intensity. Okay. We'll talk about the exceptions, right? And then squatting and passive leg raise, kind of the opposite. Um, Squatting, basically, well, actually, passive leg raise is easier to talk about first. So passive leg raise, we're just lifting the legs up or putting the patient in Trendelenburg. It's increasing the amount of blood flow back to my IVC. We increase the preload to the right and left ventricle. If we increase the preload, more venous return, most of the murmurs get louder, right? Squatting, more or less the same thing. When I squat, it compresses some of my vessels and it increases the pressure, which pushes blood back to my heart, right? So increases preload. But by also compressing these vessels, we're also increasing the afterload, right? But for the most part, by squatting and doing passive leg raise, we're bringing more blood back to the heart, so most murmurs get louder with squatting. Okay? The two exceptions, right? Hokum and MVP. Now, I don't know where you guys are at whenever you watch this video. So I don't know if you totally know about these diseases, and this lecture is not meant to be like an all like encompassing Hokum and MVP lecture. But essentially, what Hokum is, right? It's a genetic disease. Okay, there's a lot of different mutations. A lot of them tend to stem from the beta myosin gene kind of being overactive, and you'll get the interventricular septum of the heart, which the right ventricle is here, the left ventricle is here. They're connected by my two thumbs in the middle, which is called my interventricular septum, right? Um, in hokum, that interventricular septum gets massive, right? And what that massive interventricular septum does is it cuts off the left ventricle, right? So here's a normal person's heart, right? These are my ventricles. What the interventricular septum does when it hypertrophies, it moves over, and the left ventricle is now no longer able to hold as much blood as it could, right? So the classic illness script for hokum is usually it's caught at a younger age, like a kid or early adolescent or early adult. Sometimes it doesn't get caught as early, but they'll usually be playing a sport, doing a physical activity, and they have a syncopal event, right? Syncope is defined as a transient loss of consciousness, right? So these patients lose consciousness. We call it cardiogenic syncope because the left ventricle has very low preload. So hence very low cardiac output, very low stroke volume, and we can't perfuse through the internal carotids. We can't perfuse my circle of Willis, and we're not perfusing my brain, right? So the brain is at a lack of oxygen, right? And the patient passes out. Other things that can happen in hokum, you can have systolic anterior motion of the mitral valve. That's like a classic buzzword. When the interventricular septum moves over, it does weird things and it pushes the mitral valve anteriorly during systole. But so basically, now that you have that understanding, again, like hokum could be its own lecture. There are certain EKG findings we obviously diagnose with an echo, right? And then treatment is beyond the scope of step one. But essentially, right, these are the two exceptions. So your hokum murmur actually gets louder when we have decreased preload, right? So having the patient do Valsalva or stand up actually makes the murmur louder, right? So why does that happen? Okay. So in a patient with hokum, right, here's a normal heart, here's hokum. When we decrease preload, we're not filling the left ventricle as much. And all this blood has to shoot up and it's going to smack against that interventricular septum that's hypertrophied. So all the blood that's in the left ventricle is going to smack against it. We're going to hear a loud murmur. That murmur is classically auscultated at the left lower sternal border. It's systolic. Potentially it could be holosystolic, okay? But then what happens is, let's say here's my normal heart, here's my hokum heart. If I increase preload, so I do passive leg raise, or I give the patient fluids, or I have them squat, we're actually increasing the filling in my left ventricle, and we push that interventricular septum back to kind of its starting spot if it wasn't hypertrophy. And so now the cavity in the left ventricle is much larger, and so when we eject, not all of that blood has to smack up against the interventricular septum, and so the murmur gets quieter, right? So when we have the patient Valsalva, increase intrathoracic pressure, which decreases my preload, the interventricular septum that's hypertrophied is pushed over, and any blood that's in that left ventricle is going to smack, 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 smack. Murmur super loud. When I have the patient do a passive leg raise or I give them fluid, we increase the preload. It shifts the interventricular septum back over to its starting spot, and any blood in that cavity, it's got more of a free path through the aorta, so we get a quieter murmur. Similar idea with mitral valve prolapse. So mitral valve prolapse, the valve is kind of prolapsing right into the left ventricle or potentially even the left atria, depending on the severity of things. And really, what you hear is a systolic click, like it's a ejection click that we can hear, and it's from when the mitral valve prolapses, it pulls on the annulus that connect the mitral valve to the heart itself, and we hear that click, right? So think about you're holding a rope from one end, your buddy's holding a rope from another end, and you both pull it taut. You might hear that snap. right? When everything gets taut, that's the click we're hearing when we're auscultating the heart, right? It's the annulus that is they're getting clicked, right? They're getting taut. So it's the same idea here. If we decrease preload, the left ventricle is going to be smaller, and it's much easier to taut pull that mitral valve taut, right? So think about if I had a rope that was 20 feet long, right? Because we have to snap it. We're going to snap it shut if it's 20 feet long compared to a rope that's 10 feet long. We'll be able to snap the rope shut or taut with the 10-foot rope much quicker than the 20-foot rope, right? It will take much less effort. It will be quicker. Um, so in mitral valve prolapse, when we decrease the preload, the left ventricle gets smaller and the leaflet prolapses earlier, right? Um, so the click, the murmur, it happens earlier and louder with Valsalva and standing, and then it gets later and softer with squatting. So those are the big thing, right? That's a lot, right? So if you need to go back through this, re-listen to my explanation. But basically, all murmurs um, get louder with increased flow, with increased preload, except hokum and mitral valve prolapse, right? For the sake of step one and step two. These do the opposite, and I kind of explain the physiology and pathophys there. Mitral valve prolapse is actually quite common. Some literature says like 15% of the population. It's usually more common in women than men. And then mitral valve prolapse is very common in a lot of these systemic vascular collagen diseases, like systemic collagen diseases or vascular diseases. The big one being Marfan syndrome. So Marfan syndrome, FBN1 gene mutation on chromosome 15. It messes with my collagen formation. So these patients can be very tall. They can have what's called ectopia lentis, where the lenses are dislocated upwards. They can have arachidontal, right, really long fingers and toes. They can have a high arch palate. They can have pes planus, a flat foot. They can have pectus excavatum, right, a kind of a incaving chest. And then they usually have mitral valve prolapse. Their collagen is messed up, right? So they could have aortic regurgitation and the aortic widening, and it puts them at risk for aortic aneurysm. Okay. Um, those are some of the highlights of Marfan syndrome. So hand grip, we're increasing the afterload, right? I'm squeezing down on something. My systemic vascular resistance gets louder. So in hand grip, right, if we increase the afterload, we're going to get more regurgitation back across incompetent valves. So we're going to get louder mitral regurg, aortic regurg, and potentially ventral septal defect, right? So ventral septal defect, we have an abnormal communication between the left and right ventricles. Normally, the left ventricle is stronger than the right ventricle, right? So blood will move from the left ventricle to the right ventricle. Um, so if you think about it, right, if my systemic vascular resistance gets higher, my left ventricle has to push stronger in order to open up that aortic valve. But eventually, right, if the systemic vascular resistance is so high because I'm having them do the hand grip, the valve will snap shut, right? Because the pressure outside is higher than inside, but this valve is incompetent, right? So it's leaky, and so when it snaps shut, it's allowing more blood to flow back, right? And then it's the same idea for a VSD, right? The left ventricle has to increase even more pressure to beat this preload or to beat this increased afterload, and so even more blood is going to shunt through the VSD to the right side, right? VSDs are classically a holosystolic murmur heard best at the left lower sternal border. Um, but then softer would be things like aortic stenosis and often hokum, right? Aortic stenosis would be because, right, if the afterload is higher, the left ventricle is not able to push as much blood against that increased afterload, right? So there's less flow over the stenotic aortic valve, right? Boom. You've understood it physiologically, right? That goes for any of the valves, right? I'm just using the aortic valve as the example. Okay. Inspiration and expiration. When I inspire, it increases the venous return to the heart. So when I inspire, my diaphragm goes down, my chest goes out, my intrathoracic pressure does the opposite of what the Valsalva does. My intrathoracic pressure goes down. When my intrathoracic pressure goes down, there's less pressure in my chest. The pressure in my systemic venous system is higher, so it pushes more blood back to the right side of my heart. Okay, so the all you need to know, right, if that didn't make sense to you, inspiration increases venous return to the right side of the heart. So any of my right-sided murmurs, especially tricuspid regurg, is going to get louder, right? So if I increase return to the right side of the heart and I've got a shitty tricuspid valve that's regurgitant, right? More flow across the murmur is going to get louder, right? Remember our rule, all any more flow across the murmur, the valve, that murmur gets louder, except for Holcomb and MVP, right? Um, and then expiration kind of does the opposite. Expiration accentuates left-sided murmurs. The big one is understanding inspiration increases venous return to the right side. It's going to make my right-sided murmurs much louder, right? When the tricuspid regurgitation, classically a holosystolic murmur, heard best at the left lower sternal border, when that gets louder on inspiration, we call that Carvalho's sign, okay? It's a good one to know. So mnemonic, right murmurs get louder with inspiration, right? So just a real quick on some of the higher yield murmurs. Aortic stenosis is classically a systolic crescendo decrescendo murmur. It radiates to the carotids and it's often best heard at the right upper sternal border. We've already talked about why this is a systolic murmur when it's stenosis, right? So go back to my description of why that occurs, right? The left ventricle has to generate much higher pressures to pop open this stenotic valve, right? So we can get what's called concentric left ventricular hypertrophy. Squatting will typically make it louder, right? We increase my venous return. We increase flow across that stenotic valve. Hand grip often makes it softer, right? I increase afterload. It's harder to push against that increased afterload. The murmur gets softer. There's less flow across that valve. Mitral regurg is classically holosystolic. It can radiate to the axilla, and it's best heard at that cardiac apex, right? The fifth left intercostal space, usually at the midclavicular line. Hand grip will make it louder, like it does for every regurgitant lesion, right? So we increase the systemic vascular resistance. It's much harder for the left ventricle to push against that increased afterload, so fluid moves backwards. Normally, a really strong mitral valve won't allow any fluid back into the left atrium, but this mitral valve sucks. It's really leaky. We allow fluid back into the left atrium, right? So we can hear a louder murmur when we do the hand grip. Chronic mitral regurgitation can lead to left atrial dilation, left ventricular volume overload, right? So again, when that fluid backs up, it's got to go somewhere, right? If it's not going forward, it's going backwards. It can get into the left atrium and cause left ventricular or left atrial dilation. Eventually, when the left atrium gets too big, fluid can move back into the pulmonary venous system. It can move into the pulmonary capillaries. It can outweigh the hydrostatic pressure and kind of pop out of these vessels, right? If we increase the hydrostatic pressure, pop out of these vessels and cause pulmonary edema, okay? Aortic regurg, right, is an early diastolic decrescendo murmur. It can be heard both at the left and right upper sternal border. It usually presents with increased pulse pressure. So their blood pressure might be like pulse pressure is systolic minus diastolic, right? So if you think about like a normal blood pressure is 120/80. So their pulse pressure would be 40. So like an elevated pulse pressure is really, maybe not like 42, 43. Like I start thinking about it when I see like pulse pressures that are like 50, 60, 70, right? So think about like a blood pressure that's like 150 over like 60, right? That's pretty high, right? That's 90. That's a high pulse pressure. That could key you in on it's non-specific for aortic regurg, but it could key you in on aortic regurg, right? Other things can cause that beyond the scope of today's talk. But those would be things that cause high output heart failure, like thyrotoxicosis, anemia, fever, wet beriberi, anemia, amongst a few, right? You can also see bounding pulses. So bounding carotid pulses are called Corrigan's pulse. You could see head bob, like water hammer pulse, where their head literally bobs with systole because it's such a strong contraction. You can see Quincke's pulse in their fingernails, where you actually see you see their actual pulse in their fingernails, right? So those are all signs of like potentially aortic regurg. Um, like all regurgitant murmurs, hand grip makes it louder. The left ventricular volume overload can lead to eccentric hypertrophy. Okay. So a few more murmurs. We've already talked about it. Tricuspid regurg, holosystolic best at the left lower sternal border. Tricuspid stenosis, diastolic at left lower sternal border. Mitral stenosis, diastolic rumble, heard best at the cardiac apex. And then pulmonic stenosis, would be a systolic. Pulmonic regurg would be a diastolic murmur at the left upper sternal border. Okay. Um, this is from Dr. Mansour's Frameworks for Internal Medicine. Take a screenshot of this, save it, right? It's literally everything we talked about. But when you're auscultating a patient and you're like, what type of murmur is this? First decide is it systolic or diastolic, right? Pretty easily, you can palpate the pulse if you can feel it, right? If you're hearing that murmur while you're feeling the palpable pulse, it's likely a systolic murmur. If you're not feeling the pulse at the same time, it's more likely a diastolic murmur. There are other more advanced ways to kind of tell the difference, but that would be the easiest. On vignettes, they're going to tell you it's a systolic murmur, it's a diastolic murmur, or they're going to make you pick out of the answer options. So you got to know this. And then you can decide, okay, is this crescendo, decrescendo? Does it get louder than softer? Or is it a plateau or holosystolic, right? Does it stay the same level? Diastolic is a decrescendo, right? It starts loud and then gets softer. Or is it decrescendo, crescendo? It starts loud, soft, and then finishes loud. Um, so that's a good framework for you guys to think through, like I like to do for all my stuff. Okay, so just a few more slides on some other concepts, because I initially made this PowerPoint for a student I was helping with. She's about to take step one, so she wanted to go over some of these concepts, but I think it will help. So pulmonary hypertension, what does it do to the right ventricle? We've actually kind of already talked about this. The right ventricle is made for low pressure work. So when the pulmonary vascular resistance increases, the right ventricle has to work really hard. It can hypertrophy up to a point, but eventually it's gonna die out, right? It can't maintain that hypertrophy forever. It can't maintain that level of work forever. So over time, that right ventricle is going to dilate. It's going to put more stress on the tricuspid valve. And as the right ventricle dilates, it pulls the tricuspid valve longer and longer and longer. And we can get a flappy, insufficient valve, right? It can lead to tricuspid regurgitation. Um, so then all of a sudden, this right ventricle is not pumping as hard. We've got an incompetent tricuspid valve. There's less forward flow to the lungs. Less forward flow to the lungs means less flow to the left atrium, which means less flow to the left ventricle, which means less total cardiac output. Okay. And if flow isn't moving forward, it can move backwards, right? And so now all of a sudden my right atrium can get stretched. We can push fluid through my jugular veins, my internal jugular veins, and we can get elevated JVD. Flow can move backwards through the IVC, the hepatic vein, and it can stretch my hepatic capsule, and we get what's called congestive hepatopathy, right? So the patient could have right upper quadrant pain. They could have an enlarged liver. They could have an elevated ALT and AST. They could get portal hypertension. Okay, that fluid can leak out and it can lead to ascites and peripheral edema. Okay, so that's like right heart failure, secondary to pulmonary hypertension. So key consequences you should predict. We already kind of talked about it. A loud P2 or a split P2, right? So increased pulmonary arterial pressure. We already kind of talked about that. The A2 and P2 normally close around the same time. A2 is usually a little sooner, but when the pressure in the pulmonary artery increases so high that pulmonic valve takes a while to snap shut, and you can hear a loud P2 that's a little bit delayed. We've already talked about this. I just mentioned this. And then you can get septal and flattening shift. When you get really severe right ventricular pressure, the septum shifts over almost like in hokum, and then it's really hard to fill the left ventricle. So now the ventricles aren't really working as a tandem, right? We call it interventricular dependence. So again, the septum kind of flattens or it shifts over, really hard to fill the left ventricle. So we've essentially reduced the compliance of the left ventricle. All right. So why does hypoxia worsen pulmonary hypertension? You guys will learn about this if you haven't done your respiratory unit yet. Almost every organ system, or actually every organ system, they will dilate in times of hypoxia, so low oxygen. The lungs do the opposite. So the lungs actually will cause constriction. And I'm not going to go too deep into this because that's not the point of the lecture. But again, when we breathe in air, we eventually go through the trachea, the bronchioles, the bronchi, the bronchioles, and then we make our way to the alveoli. The alveoli are in line with a capillary. That capillary is pulling red blood cells across. The red blood cells have hemoglobin. We add oxygen, 4 molecules of oxygen to the hemoglobin. We release CO2, we breathe off CO2. What happens is when the patient's alveoli aren't working properly, your lungs are really smart. And it's like, hey, we're not getting oxygen here, even though we're perfusing these alveoli, right? And so your lungs are like, why would I waste sending blood to an area we're not getting oxygen? So it constricts those vessels that are going past the really bad alveoli. So we shunt all the blood over to good alveoli. Okay. Again, you'll learn more about this in respiratory, but essentially what's happening, right? Yes, we're improving oxygenation, but what did we just do? We just constricted all of my pulmonary vessels, not all of them, but a lot of my pulmonary capillaries and pulmonary vessels, right? And so the pulmonary vascular resistance went sky high. So when you have a patient with like COPD or interstitial lung disease or a lot of these lung conditions, and they're chronically hypoxic, all we're doing is, man, we're just constricting these blood vessels even more, and that pulmonary vascular resistance is going sky high. The right ventricle has to work even harder. We're going to lead to right heart failure pretty quick, right? So kidney failure, again, if you haven't done renal yet, this is going to be tough. But ask yourself, is it a perfusion problem or is the kidney damage intrinsic, right? So there are three types of acute kidney injuries. There's pre-renal, so we're not getting forward flow to the kidney. There's intrinsic damage to the tubular system itself, or there's post-renal, where there's some sort of obstruction and then fluid is backing up, causing overflow of the kidneys themselves and causing damage. We'll talk more about this when I do more renal videos and when you guys get to your renal lecture. Um, but again, pre-renal is often due to heart failure or low forward flow, right? So if there's a lack of cardiac output, we can't perfuse the kidneys, right? The kidneys need about 25% of the cardiac output. So they're very volume sensitive, right? So when there's a low forward flow, my JG cells, my juxtaglomerular cells are like, we do not like this, right? Low sodium, low forward flow, and then increased sympathetic output are the three things that stimulate the RAS, right? The renin. Renin gets made, we convert angiotensinogen to Ang1. Ang1 gets converted to Ang2. Ang2 does all bunch of things, right? Like systemic vascular vasoconstriction. It constricts my efferent arterial to increase the GFR. It goes down to my zona glomerulosa. We increase aldosterone production, right? And then we can also increase the release of antidiuretic hormone, okay? All to try to keep sodium in water, vasoconstrict to get the systemic vascular resistance high enough and try to augment that cardiac output. Um, Again, if you haven't done renal, these values might not make sense, but the BUN to creatinine ratio is classically above 20. The fractional excretion of sodium is less than 1%, right? Because what do these things like to do, right? Angiotensinogen, and aldosterone help us keep sodium in water. So we're going to not dump sodium into the urine. We're going to hold on to that sodium, right? So if it's a pre-renal cause and renin and angiotensin system are sky high, we shouldn't be dumping sodium into the urine. So the FeNA, the fractional excretion of sodium, is less than 1. When it's intrinsic, okay, so things like prolonged pre-renal AKI or certain drugs like vancomycin, gentamicin, amphotericin B can cause intrinsic acute tubular necrosis. The tubules of the kidney system necrose, right? They can't work, so they can't reabsorb sodium. So in this case, we're going to dump a lot of sodium into the urine. So the fractional excretion of sodium is like greater than 2%. And the BUN to creatinine ratios tends to be a little bit less, like 10 to 15. And we'll see these muddy brown casts. They're also called granular casts. More to come in renal. All right. Why does the BUN to creatinine change disproportionately? The BUN rises more when the urea reabsorption increases. So in pre-renal states, there's really slow tubular flow because there's less blood getting to the kidney, so it allows more time for the urea to be reabsorbed. I'm not going to talk about these now because that can get too tricky. You guys have done your GI unit. In the GI unit, right, my blood, if the patient has an upper GI bleed, that blood is high, high, high in nitrogen compounds, right? Those nitrogen compounds get broken down into B, or like it's literally the BUN is your blood urea nitrogen, right? So we're gonna abnormally sense in a lab assay, we're gonna see that their BUN level is pretty high, right? Um, so one pretty sensitive marker for an upper GI bleed is a BUN to creatinine ratio greater than 30. So again, that blood that they're bleeding and starting to digest, really high nitrogen load is going to increase their BUN. Um, So again, that's why the BU and the creatinine ratio tends to be above 20 in pre-renal, but not as high in intrinsic, because in the pre-renal states, more urea is reabsorbed. Um, and then that little tidbit on the GI bleed. Okay. Real quick, cardiorenal syndrome, right? In cardiorenal syndrome, there's low cardiac output, right? If fluid can't move forward, it moves backwards, and eventually it leads to venous congestion, right? So the renal veins themselves get really overloaded, and that decreases the perfusion gradient, which really damages my kidney. And when we decrease the renal perfusion gradient, the renin-angiotensin and ADH system gets activated. We get sodium and water retention, and that worsens heart failure. Okay. Really, what I want you to know about cardiorenal syndrome, it's not necessarily the low forward flow to the kidney, it's the back flow of the kidney and the venous congestion that is the big cause here, because that venous congestion decreases the renal perfusion gradient, leading to kidney damage. And then vice versa, how could CKD lead to heart failure? Well, that could be from chronic volume retention and hypertension. It could be from uremia itself causing cardiomyopathy, anemia from a lack of erythropoietin from the peritubular fibroblast can lead to high output stress. And then CKD can cause a lot of vascular calcification, which can increase afterload and left ventricular hypertrophy. Some advanced concepts. Vomiting and volume status. Um, so volume status is really hard to measure. I could do a whole lecture on that. Not the purpose of today. But when you vomit, you lose hydrochloric acid. When I lose my acid, it can lead to metabolic alkalosis. A lack of forward flow to the kidneys, right? Because we're in essentially, I'm puking out multiple liters of my fluid, right? And so now we're in a pre-renal state. We're not perfusing the kidneys as well. We activate the RAS system, and one of those things, aldosterone, keeps sodium in water. We remove potassium and H plus, so we can lose potassium, and we're losing more H plus. We're losing hydrochloric acid, so we can get what's called hypokalemic metabolic alkalosis. Okay. Um, I won't talk about, I have a whole lecture on hyponatremia. Obviously, if we're puking, we can lose sodium in the puke as well. You can read more or learn more about hyponatremia by watching my video. But my key concept, there are three things that really activate antidiuretic hormone. It's low forward flow, so low blood volume. Okay. It is high tonicity or high solutes, sodium being the biggest one. And then it's pain, vomiting, things along those lines that can activate ADH as well. It's really the low forward flow that drives antidiuretic hormone the most. Okay, so if there's a low amount of blood volume, antidiuretic hormone should be high. Okay. Um, Pulmonary edema, right? We've kind of already talked about this. It could be cardiogenic or it could be non-cardiogenic. So in cardiogenic, as the left ventricular filling pressure increases, it can't go forward all the time, right? Especially if we have a dying left ventricle that can't push, that can't contract, or it can't fill as well, right? So that's systolic when it can't push. It's diastolic heart failure when it can't expand, right? It's less compliant. And so fluid moves back, it causes increased left atrial pressure. We can measure that by what's called the post-capillary wedge pressure. So if you ever read in a vignette or a question, there's elevated PCWP or post-capillary wedge pressure. That's telling me the left atrial pressure is higher than it should be. And so then fluid moves back into the pulmonary veins, and then it overwhelms the pulmonary vascular system. Hydrostatic pressure increases, right? Three mechanisms of anemia, edema, sorry, increase hydrostatic pressure, decrease oncotic pressure, increase capillary permeability. In this case, it would be secondary to increased hydrostatic pressure. We overload the pulmonary system. We have fluid where it shouldn't be in the interstitium, and then we can get pulmonary edema. But non-cardiogenic pulmonary edema could be things like ARDS, which again, if you haven't done your respiratory unit, totally okay, but it's usually some other huge inflammatory condition causes a bunch of neutrophils to get really angry and come and attack the lungs and cause all my vessels to be really leaky. We can lose a ton of fluid into the pulmonary vascular system, really damage the alveoli. And so you'll see fluid in these lungs without a high wedge pressure. They're pro-BNP, right? Their brain natriuretic peptide that's usually elevated when the ventricles stretch. Their BNP, as long as they don't have underlying heart problems, their BNP should be normal or within normal limits, right? Um, So just because you see pulmonary edema doesn't mean there's too much preload or that the heart's failing, right? It could sometimes mean you have a leaky membrane, like an ARDS. And again, if you haven't done respiratory, you'll learn about this. ARDS, these are the Berlin criteria. How do we diagnose it? The symptoms begin within 1 week of insult, or they're new or worsening. We see bilateral opacities on the chest imaging. Their PA2 divided by FiO2 is less than 300, and then it can't be fully due to a cardiac or volume overload state. Um, Diuretics, again, you'll cover this in renal if you haven't done your renal block yet. Loop diuretics are the most powerful. They block my sodium potassium 2 chloride. They can lead to the sodium potassium 2 chloride channel in my thick ascending limb of the loop of Henle. They can cause hypokalemia, metabolic alkalosis. Thiazides will block the sodium chloride co-transporter in my distal convoluted tubule. Um, these can cause hypergluc, right, is the mnemonic for it, right, because it can cause increased glucose, lipids, uric acid, and calcium. We can have potassium-sparing diuretics like spironolactone or eplerenone, which block mineralocorticoids, or we can have ENaC channel blockers like amiloride or triamterene that block the ENaC channels that can then lead to a buildup of potassium. Obviously, right, if we're blocking aldosterone, aldosterone keeps sodium in water, kicks out potassium and H+, so we can have potassium increase, right, and we can lead to hyperkalemia. I think that's what I'll say for that, right? That the student wanted just a quick recap on diuretics. So I put that in there. Diuretics come up in your cardio unit, even though you haven't like fully learned them. So I'm happy. Please send me an email. Happy to go over diuretics more in depth if you want. Um, so let's do a practice case really quick. We have a 19-year-old college athlete is being evaluated for a newly detected heart murmur. On exam, you hear a harsh murmur best at the right upper sternal border that peaks in mid-systole. The murmur is clearly heard after S1 and before S2, and it radiates towards the neck. So I want you to think about what is the most likely valvular lesion. Okay, explain why the lesion produces a murmur during that part of the cardiac cycle, and state which valves are open versus closed when I'm hearing the murmur, right? So pause your screen, consider these 3 questions, and then I'll go over it. So this lesion would be aortic stenosis, right? It's right upper sternal border. It's systolic. It's harsh. It's radiating to the carotids. That's aortic stenosis, okay? Um, Most of the time we don't see aortic stenosis until the patient is like, 60, 70, 80 years old, right? Due to prolonged calcification and fibrosis. When I see it in a really young person or like a person less than 50, I start thinking about bicuspid aortic valve. My aortic valve should have 3 cusps to it. When it only has 2, it's predisposed to early calcification and fibrosis that can lead to early onset aortic stenosis, right? Another classic disease that's associated with bicuspid aortic valve is Turner syndrome, 45XO, right? You'll learn about, if you haven't learned about it yet, you'll learn about it in your repro unit in your respective medical schools. Um, so why is this a systolic murmur, right? The aortic valve is supposed to be open in systole, right? When the valve is stenotic, turbulent forward flow from the left ventricle to the aorta is going right across that stenotic valve, and you're going to hear a really loud murmur, right? Because that valve should be wide open, but it's stenotic. It's rusty. It doesn't want to be open. So we're going to have to push really hard against that stenotic valve, and we're going to hear a really loud murmur in between S1 and S2. And then the valve states during the murmur, right? This is systole in between S1 and S2. So the aortic and pulmonic valves should be open. The mitral and tricuspid valves should be closed. All right, let's do another case. A 28-year-old man has intermittent chest pain and pre-syncope during exercise. A systolic murmur is heard along the left sternal border. When he performs a Valsalva maneuver, the murmur becomes louder. When he squats, the murmur becomes softer. What diagnosis best explains this murmur behavior? And then use the preload left ventricular volume logic to explain why. Valsalva makes it louder, squatting makes it softer. And then if you can, in one sentence, connect this to pressure gradients, flow, like, so what's changing about the left ventricular obstruction or the left ventricular volume? So pause and think about it. So this is a classic illness script, classic vignette for HOCM, right? We have a relatively younger man, chest pain, pre-syncope during exercise, and then that that systolic murmur against the left sternal border that is then changing with Valsalva, right? So remember, Valsalva decreases preload, so most murmurs get quieter. If the murmur is getting louder, it kind of leads to two things, right? It's either hokum or it's MVP. MVP usually doesn't cause chest pain or syncope or pre-syncope. Hokum definitely could, right? So it's more likely hokum, right? Um, so the mechanism, right, the Valsalva decreases your preload. It leads to a smaller left ventricular cavity. The obstruction worsens and the murmur gets louder, right? Squatting, the exact opposite. The preload increases, so does afterload, right? But the preload is the big one. We get a larger left ventricular cavity. The obstruction decreases and the murmur gets softer. Okay. Um, and then the pressure flow tie-in, as the smaller left ventricular size increases, the dynamic left ventricular outflow tract obstruction, or sorry, like the smaller left ventricular size increases that outflow tract, right? The obstruction. So it increases the turbulent flow. It's basically what I set up here. So the smaller the left ventricular size is, the more that left ventricular outflow tract out through the aorta is compressed, the stronger the turbulent flow, the stronger the murmur. We literally just said that, right? This was just kind of saying it in a different way. All right. And then number three, 64-year-old man or woman with long-standing hypertension has dyspnea on exertion. On auscultation, you clearly identify S1, followed by a pause, then S2, followed by a longer pause. You're asked to teach a junior student what is happening mechanically during these intervals. So define S1 and S2 in terms of which valves are closed. For the interval between S1 and S2, describe the ventricular mechanical state. So are we contracting or relaxing? Which valve groups are open or closed? For the interval between S2 and the next S1, describe the same. And then if you heard a diastolic murmur while auscultating this person, name two broad valve categories that could produce it and explain the timing rule. Okay. A lot of things to think about. So pause and I'll go over the answers. Right. So S1, the mitral and tricuspids are closed. So that's the start of my systole. S2, the aortic and pulmonic valves are closed. That's my start of diastole. S1 to S2 is systole. The ventricles are contracting or ejecting. The AV valves, right? So those are my mitral and tricuspid valves, are closed. The semilunar valves are open, right? Aortic and pulmonic valves. So remember the AV valves, the atrioventricular valves, are another name for mitral and tricuspid, and semilunar are another name for aortic and pulmonic. S2 to the next S1 is my diastole. So here my ventricles are relaxing and filling. The AV valves, mitral and tricuspid, are open. Semilunar valves, aortic and pulmonic, are open, or sorry, are closed. So bonus, the diastolic murmur rule. So either we could have aortic or pulmonic regurgitation. Okay, so they should be closed in diastole, or we could have mitral or tricuspid stenosis, right? So essentially in diastole, it's either, if I hear a diastolic murmur, right, it gets a little more complicated than this because both S3 and S4 are technically diastolic murmurs, but for the sake of my discussion today, right, diastolic murmurs, we're either thinking aortic or pulmonic regurgitation, right? Because those vessels or those valves should be closed during diastole, or we're thinking mitral tricuspid stenosis because those valves should be open during diastole. Okay, so kind of think about how all that physiology works. All right. This was a lot of information. Hopefully it helped a little bit, kind of clear up some of the cardiac phys. I kind of introduced you guys to a couple new topics for respiratory and renal. I didn't go too much in depth, so hopefully I didn't confuse you guys too much, but please email me. Happy to go over any of these concepts in more detail. All right, let me know. See ya.